Good evening, respected teachers. Myself, Dr. Richie, I am going to present a seminar on topic oncoplastic-based surgery. Starting with the introduction, uh, initially the breast conservative surgery has become the standard of care for early breast cancer with excellent survival rates. 5 year survival of breast conservative surgery with radiation is similar when compared to mastectomy alone in patients with stage 1 or 2 breast cancer. However, the focus of breast conservative surgery has now shifted to cosmetic outcome, quality of life, and patient satisfaction. Now, what are the indications for oncoplastic surgery? For oncoplastic surgery, uh, young females and males having early breast cancer, stage 1 and 2, consent is very important, and post mastectomy defects, unsatisfactory outcome after breast conservative surgery. So we prefer oncoplastic based surgery in such cases. And what are the contraindications? They are extensive multicentric tumors, advanced breast disease, T4 stage, extensive malignant microcalcification, inflammatory breast cancer, extremes of age, obesity, and severe comorbidity. Now there is a phase of transition. Initially, we used to prefer radical mastectomy. Later, it is modified to modified radical mastectomy. Then breast conservative surgery came into this procedure came. Then now we are focusing on oncoplastic breast surgery. Now, what is oncoplastic breast surgery? Uh, Oncoplastic is a Greek word which means molding of the tumor. Werner Odrich is the father of oncoplastic surgery. Oncoplastic surgery is a new approach. It allows a wide excision of breast, uh, a wide excision for breast conservative surgery without compromising the natural shape of the breast. It combines the principle of oncologic and plastic surgery technique to obtain oncologically sound and aesthetically pleasing results. Now, classification on oncoplastic surgery, it is based on the tissue excision and surgical difficulty. Type 1 oncoplasty, oncoplastic procedure or local tissue arrangement via raising parenchymal flaps. Type 2 oncoplasty, here both significant parenchymal and skin resections can be done. Three considerations are important for oncoplastic procedures. These are the volume of the tissue to be excised, and it is compared with the total volume of the breast. Second is the tumor location, and third is breast size and glandular density. Starting with the excision of volume of the breast, it is based on the two concepts, volume displacement procedure and volume replacement procedure. In volume displacement procedure, there is local tissue rearrangement and reduction mammoplasty. Where in volume replacement procedure, we use autologous tissues from an extra mammary sites. It can be latissimus dorsi flap or tram flap or uh, 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 any flaps from the gluteal region. So any extra mammary sites tissue we prefer for this volume replacement. Location. Tumor location is important for consideration for oncoplastic breast surgery. Tumor located in upper outer quadrant are better for this oncoplastic surgery procedure and does not leave any deformity, whereas a tumor in the upper and inner quadrant and the lower pole of the breast, they particularly lead to the deformity, mainly the bird beak deformity. When the tumor is located in the lower pole of the breast. Size and glandular density, breast size and glandular density. So oncoplastic technique for each patient varies based on the size of their breast. A smaller breast require different method of reconstruction with a large volume of tumor resection. The recruitment of the local flap is required. Whereas a large breast, patient with a large breast afford oncoplastic surgeon more option for surgical creativity. Now in detail, volume displacement procedure, rearrangement of the breast parenchyma to create a homologous redistribution of volume loss. Loss in breast volume and contralateral surgery is usually required to restore the symmetry. The options are adjacent tissue rearrangement and mammoplasty technique. The adjacent tissue rearrangement includes the steps: accurate decision of the skin incision. Preoperatively, we have to mark the incision over the skin. Then skin undermining is done, followed by nipple areolar complex undermining. Then gradual reapproximation and deepithelialization is also done. And finally, the nipple areola complex repositioning is done. And it should be compared with the contralateral breast also. Mammoplasty technique, it allows the reconstruction of resection defect with parenchymal flap using different approaches, superior pedicle approach and inferior pedicle approach. The superior pedicle approach is for the tumor located in the lower quadrant of the breast, and inferior pedicle for the defects in the upper pole of the breast. Now, based on the site, oncoplastic surgery can be for different sites of the tumor. Peripheral tumor. Peripheral tumor, we generally do lumpectomy, bat wing mastopexy, rotation flap, round block technique, tennis racket technique, reduction technique, and inframammary breast flap. For central tumor, we use purse string suture, horizontal technique, and mammoplasty associated technique. For peripheral tumor, simple excision of the lump up to the prepectoral fascia, followed by glandular reshaping to maintain the shape and followed by simple closure. In bat wing mastopexy, it is also called inverted V or omegaplasty. It is for superior quadrant and superior medial tumor. Rotation flap, it can be used for any site of the breast tumor. We draw two curvilinear line, one along the margin of the NAC and one along the margin of the breast, and both lines are joined together and around the lump, and the lump is removed, followed by volume displacement procedure. So to restore the normal shape of the breast. Fourth is the round block technique. It is used for the tumor located near nipple areola complex without nipple inversion. We use two circular incisions, one along the lateral border of the nipple areola complex and 2 centimeter beyond this. We also make a circular incision and deepithelize the skin, followed by the removal of the tumor around the NAC, and simple volume displacement procedure is performed to restore the shape of the breast. This is a tennis racket technique. Either here any tumor near to the NAC can be removed, and by the volume replacement technique, we make a tennis racket incision and remove the disease, followed by simple closure. This can be medial, lateral, J-shape mammoplasty. Now, reduction technique. Reduction technique is large volume breast and ptotic breast. In that, the reduction of the other breast also done at the same time. Advantage are cosmetic, functional, and oncological advantage. Inframammary breast flap. It is a new technique by using inferior flap from the residual breast to fill the defect. It is suitable for upper outer quadrant tumor. Now, for central tumor, it is 5 to 20% of the breast tumor are central tumor. Several technique has been used depending on the size. In that, the purse string suture and horizontal techniques. Both are shown. In purse string suture, we just close the defect by purse string suture, and after removing of the tumor, we close the defect by purse string suture, and shape of the breast is maintained. And second is a horizontal technique. Now third is in central tumor is mammoplasty associated technique. If the tumor is large and deeper and breast volume allows, the breast reduction can be performed in association with nipple areolar complex removal. A symmetrization on the contralateral breast is also required. Now, after the breast reconstruction, there is a important thing is nipple areola complex reconstruction. It is usually done, nipple reconstruction is usually done 2 to 3 months after the breast reconstruction, and areola reconstruction is usually done 4 to 6 weeks of the nipple reconstruction. It is done in a second setting, either by areolar skin grafting and or by areolar tattooing by local flaps. Now, second is volume replacement. Using these technique, autologous tissue is harvested and transferred from a remote site to the resection defect. Autologous reconstruction can be a tram flap, LD flap, abdominal based flap like DIEP and SIEP, gluteal flap, Rubens flap, thoracoepigastric and lateral thigh flaps. Most commonly used are tram flap, LD flap, and DIEP flap. Second is a alloplastic reconstruction. Alloplastic reconstruction, we use a foreign material to within the breast for reshaping of the breast. It is a silicon gel implant. silicon implant with the saline fill. Silicon injection is also used. Smooth wall and textured wall. And combination with the tram flap, these implants can be also be used. And with LD flap, this silicon implant can also be used. Now, autologous reconstruction, starting with autologous tram flap, it is a gold standard due to similar in consistency with the breast tissue. It has a dual blood supply from the superior epigastric and inferior epigastric vessels. Free transverse rectus abdominis myocutaneous flap is also available, and pedicle transverse rectus abdominis myocutaneous flap is available. Then the pedicle transverse rectus abdominis myocutaneous flap uses a superior epigastric artery, and whereas free transverse rectus abdominis myocutaneous flap uses a deep inferior epigastric artery. Then zones in the tram flap, it is divided into 4 zones, 1, 2, 3, 4. Zone 1 is the flap which is used for the reconstruction. It has a higher blood supply. So followed by zone 2nd, which is just contralateral to the side used for the best reconstruction. Zone 3 is most lateral to the flap that is harvested, and zone 4 is more far from this opposite contralateral, more far. So its blood supply is less and higher chance of necrosis. Indications, it is for all size of the breast can be used. This can be used, and for ptotic breast. Contraindications are if there is previous abdominoplasty procedure has been performed, so we can't harvest this tram flap. It is unable to and a patient who is unable to tolerate a longer surgery, so tram flap is not used. And smoking, if a patient is a smoker, and so it is difficult to use tram flap as a microvascular perfusion is very low in a smoking individual. So after surgery, there is a chances of graft flap loss. So that's why it is not preferred. And in abdominal liposuction procedure has been if previously performed, then also this tram surgery is contraindicated. Then this is muscle sparing tram. In this, only muscle surrounding the perforating vessel is taken. And next is a deep inferior epigastric perforator flap. Here no muscles is taken, so less chances of incisional hernia in case of DIEP flap. And next is a superior inferior epigastric, superficial inferior epigastric artery flap. And second is a latissimus dorsi flap. It is a muscle only flap with a skin island. It is based on thoracodorsal vessels. It is a myocutaneous flap with a or without a breast implant or a tissue expander. This can be used. And advantage one disadvantage is this can't be used for a very large size breast and for reconstruction of bilateral breast. So LD flap is preferred for a small size breast. Indications for LD flap: a small breast with minimal ptosis, and abdominal donor site is unavailable, like a scar is present or previous surgery or lack of tissue is there. Contraindications are planned post-operative radiation therapy and very large breast and bilateral reconstruction. Next is the Rubens flap. It is based on the deep circumflex iliac artery. The fatty area over the iliac crest is taken and used as a flap for the reconstruction of the breast. Then what are the complications of autologous reconstruction? There can be a partial or total flap loss, flat necrosis, wound infection and breakdown, seroma at the backside. It is most common with LD flap, flap necrosis, abdominal weakness and bulge, and hernia also. Now, next is an implant-based reconstruction. First of all, we'll discuss the indications. Indications for the implant-based reconstruction, it is used for a bilateral breast reconstruction and a patient not suitable for long surgery. Lack of adequate abdominal tissue is another indication. Patient not willing for abdominal scar at back and abdomen, and a small breast wound with minimal ptosis. What are the contraindications? First is silicone allergy, previous failed implant, need for adjuvant radiation therapy, very large breast, very ptotic breast, and implant fear. What are the complications? Most common complication is a capsular contracture, infection, seroma, skin necrosis, slough, and deflection. Tissue expander. This is a form of reconstruction. It begins with the tissue expander placement at the time of mastectomy and exchange for implant after the expansion. Here, with a syringe, we continuously inject the saline solution so that the tissue get loosened, and we can later put a implant, or when the tissue get loosened, and we can expand the breast. What are the indication for tissue expansion? Small to moderate ptotic breast, intact pectoralis major muscles, bilateral reconstruction, unwilling or unfit to undergo autologous tissue reconstruction. And what are the contraindications? They are radical mastectomy defect, chest wall tissue or thin or damaged or inelastic, or some radiation has done, and extensive infraclavicular tissue deformity or a vertical mastectomy scar. Timing of reconstruction is important. About the timing of reconstruction, it can be immediate or delayed. There is some benefit for immediate approach. These benefits are psychological benefit to the patient. At a time, at single surgery, patient can be benefited by mastectomy also, removal of the lump also, and followed by the reconstruction of the breast also. Second is the cost effective. So at the time of lumpectomy, if we do the reconstruction, then it is cost effective for the patient. And since the oncological outcome is same, just after the reconstruction, or if we delay the reconstruction, then no any studies has said that not any so much oncological outcome is different, and there is no scar of fibrotic tissue. Breast reshaping is easier, and aesthetic outcome is improved. What are the limitations of oncoplastic surgery? Additional procedure would result in complication, and National Surgical Quality Improvement Program confirms that the use of oncoplastic surgery does not increase the risk of surgical complication despite of longer operative time. Concerning late complication, the most common event is related to fat necrosis, glandular necrosis. Radiation therapy played a significant role and contributed to development of fat necrosis. In some cases, calcification and fat necrosis can simulate tumor recurrence. So final conclusion is oncoplastic surgery is a significant advancement in the surgical management of a breast cancer. It facilitates the removal of large volume of the breast tissue with significantly improved cosmetic outcome and patient satisfaction. It potentially reduces re-excision and mastectomy rate.
When to use a tissue expander if the patient needs a post-operative radiotherapy? Should an implant be replaced with should you put this tissue expander at the time of surgery and put an implant before the patient goes to radiation, or what is the best way forward?
No, ma'am, we will not place an implant just before radiation. So after the radiation is over, then only we can place the implant, because after radiation,
would you place a tissue expander at surgery, or you will do nothing in this?
I will not put a tissue expander before surgery. Before patient require radiotherapy.
So would you put something over there, or you will just leave the patient? Means you will do something immediately or do everything delayed?
I will wait for adjuvant radiotherapy. Then after the patient, after adjuvant radiotherapy, we will call patient for follow-up and perform this procedure.
So he is in favor of a total delayed procedure in case RT is
Delayed procedure, yeah.
But it's not mandatory. It's not mandatory.
Okay.
Many people will like to put in a tissue expander and replace with an implant before the patient goes for radiation. Obviously, over a tissue expander, you cannot have radiation. There can be higher chances of loss and everything that you have to take. So there is one very unique complication that used to happen with older type of implants. It was a serious complication. You should have made a passing remark on that. What is it?
Implant, ma'am, capsular rupture and capsular contracture.
It was serious. Capsular, it is not serious. It's cosmetically bad.
It was, ma'am, connected to the order with the silicone gel implants.
Connective tissue, it is a diffuse large B-cell lymphoma that has been reported with. You must remember that. Today's generation implants do not carry that risk.
Any question from students?
Yes, sir. Suppose, sir, if we keep a tissue expander in the surgery and we plan to use it, how long can we keep the expander? In the adjuvant setting, patient will be receiving chemotherapy, and to complete chemotherapy and radiotherapy, it might take some time. So, how long can we keep the tissue expander?
Sir, we will call the patient for follow-up and we check the skin flap pliability. And if the tissue expander we placed, if skin becomes pliable enough to resustain this implant, then
Question is how long you can keep the expander. Is there a time limit for which you can keep expander, or
And
there is no time limit?
and do you modulate the size of the implant with time? What is your target? I mean, why do you put this expander in the first place?
to loosen the underlying muscles so that the implant can be placed and give a proper shape of the breast.
Yeah, so you want to create an adequate pocket for the
Adequate
implant
pocket. Ji,
which matches the other side.
ji.
It cannot be achieved in one go in a large majority of patients. So how long can you keep it? Is there any time limit?
I have not read about time limit.
I also haven't read. Dr. Pandey?
Like, there is no hard and fast rule that how long it has to be kept, because most of the people, especially HER2 negative, will be going for about 1 year of Herceptin followed by radiation. So the duration of implant can go as much as 12 to 15 months.
No, but you
But
will
then,
not be needing a tissue expander to sit there for 12 to 15 minutes. I think the desirable results will come in a couple of
but
months.
if you are planning to give radiation after 15 months, you probably would not like to put an implant before you give radiation.
But you cannot give radiation on a tissue expander.
Yeah, you cannot.
It's not like, it's not like cobalt radiation, we do it here. So there are very nice techniques which do not scar the breast that badly. So I think you should have elaborated on this, which is more important.
That is the question, Richie. If you have already done a rotation flap, then how will you know where your margin lies? The question, Richie, is that how would you know that which margin is where? Once you do a rotation, then how will you know that what was at 7 o'clock is now where? So are you going to do a full cavity excision all around?
Yes,
Or you do something else at the time of surgery to help you identify in case you have to go in
at
again?
the time of surgery, I will mark the site. I will mark the tumor site. What tumor I have removed. I will mark the position of the superior, inferior lateral, and by that,
Yes, that's one of the technique that you mark your tumor cavity before
yes.
you mobilize your flaps for oncoplastic surgery. Suppose if you have not marked and done an oncoplastic surgery, then what you do?